Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Dr. Peter Grayson in Bethesda, Maryland, with whom we would like to discuss Vexas, which is a newly described disease entity midway between rheumatology and hematology, and thus of interest to everyone who loves internal medicine. Peter, thanks for being with us this English evening, this East Coast afternoon.
Thanks for having me.
Dr. Grayson is internist and rheumatologist. He's at the National Institute of Arthritis and Musculoskeletal and Skin Disease, the Vasculitis Translational Research Program Acting Director, very long title actually. And in context of today's talk, he's senior author of the December 2020 New England paper, which firstly described the clinical picture and the pathophysiology of Vexas. Another privilege is to have two co-moderators who are themselves academic and clinical leaders in autoinflammatory and autoimmune disease, respectively, namely Dr. Lachmann from London, UK, and Dr. Kronbichler from Cambridge, UK, and Innsbruck, Austria. My name is Gunnar Heine from Frankfurt, Germany. So another premiere at Marcus at Home, first time, 4 people from 4 countries. And I have to admit that it was actually Andreas' discussion with Helen Lachmann on amyloidosis some weeks ago when I first heard about Vexas. And I'm surrounded in Germany by other nephrologists who also have remained uninformed about Vexas until now. That's why Andreas suggested to invite you, Peter, and to end this germ ignorance. And again, we are so happy that you accepted our invitation and that you are with us tonight. So Andreas will start this talk with a clinical case.
So I can also I would also like to thank Peter and Helen for accepting the invite. And we decided to start with a case actually also to form the basis for tonight's discussions, and of course also to introduce this disease to the audience of Marcus at Home, which is particularly focusing on nephrologists. So this man actually presented first time in 2017 with inflammation of the right pinna joint pain and inflamed eyes. And he was referred to the Cambridge Vasculitis Clinic in 2019 with a diagnosis of relapsing polychondritis and a failure to achieve remission after methotrexate was started. He then presented with shortness of breath, which is quite a distinct feature of his disease, always when his hemoglobin is dropping below 80. Then he received azathioprine and developed a rash, and finally mycophenolate. We as nephrologists love that. It's probably not that effective, and developed some infectious complications. His striking feature was always when he was reduced below 20 milligrams of prednisolone, his symptoms deteriorated and his CRP shot up to the 100s. At the time of presentation to our clinic, his CRP was 46 and the ESR was 77. He always had episodes of worsening symptoms, historically, also when the steroids were reduced below 20 or then further downstream, also below 15 milligrams. And when he increased his steroids to 30 milligrams, actually symptoms improved. After he had a drop in his hemoglobin initially from 110 to 80, we performed a bone marrow biopsy in 2022. And this showed a hypercellular bone marrow with a pre-lineage dysplasia, no excess of CD34 positive cells, and no evidence of a lymphoid or plasma cell neoplasm, consistent with a diagnosis of MDS. In the aspirate, we found some progenitors appear vacuolated. Pathogenic variant in UBA1 was found after we considered Vexas as a potential differential diagnosis. So basically this is just giving us an outline, and I just wanted to start with one simple question, asking Peter if this is a typical story you are also encountering in your clinic.
Yes. So it's funny that, the disease was first reported, under 2 years ago. And I can tell you that this is a classic case of the disease. But this is pretty typical standard Vexas case for a number of reasons. The first thing is that the patient's male. The second thing, the patient is older, or that it didn't quite catch his exact age.
Go at 60, yeah.
The third thing is the patient has ear chondritis, and this diagnosis of relapsing polychondritis, which is a super common clinical diagnosis in patients with Vexas syndrome. And then the prednisone threshold, below a certain threshold, the immediate flare, high rise in acute phase reactants, very, very typical of the disease. And then the bone marrow biopsy findings are also very classic, where you're seeing hypercellular marrow being interpreted as possible MDS. And in the aspirates, you saw vacuoles. So vacuoles on the erythroid myeloid precursors and the aspirates. The treatment refractory nature of the disease, and then finally you genetically confirmed the UBA1 mutation. So this is about as typical a Vexas case as you can get.
So leading on, what are the most frequent clinical findings in your patients actually with Vexas?
Well, I think one of the important things about Vexas is because it's new, the phenotype is expanding. And when we first saw this disease, we saw it from the perspective of being rheumatologists, getting a lot of weird, atypical systemic inflammatory disease syndromes referred to us. And so for us, the initial descriptions of Vexas are probably more slanted toward that. And I suspect as time goes by, we'll see patients maybe with less severe inflammatory phenotypes and more hematologic phenotypes, and it will blur. But from the inflammation side, the most common things are fever, chondritis of the ear and the nose, skin involvement with a whole variety of rashes, but really severe rashes that can be vasculitic, neutrophilic dermatoses. Lung involvement is very common with ground glass infiltrate that can get patients quite sick very quickly, as well as effusions and serositis type disease. And then a really high signal of thromboembolic disease.
So a completely unrelated question, but just to ask you about the epidemiology of the disease. If you have a male patient over 50, how frequent do you see a UBA1 mutation in the general population? And of course, there have been some case reports and small case series about women affected by Vexas. How frequent is it actually in women?
So when we first found these, we found 3 men that had a UBA1 mutation in a genotype first approach. So David Beck, who is a clinical geneticist at the NIH, was analyzing genetic data, and out of around 2,560 patients whom we had whole exome data, he found 3 men that had these UBA1 mutations. And of course, the first thing we did was look to see if these mutations were common in the general population. So if you look at public databases like NOMAD, where you have over 200,000 healthy controls, there were no patients that had UBA1 variants. UBA1 mutations and variants in UBA1 in the distal part of the gene are associated with a congenital disease known as spinal muscular atrophy. But the Vexas syndrome UBA1 mutations are really clustered around a hotspot in the gene, codon 41. And if you look in healthy populations, you don't find these mutations. So we think that this is likely a very penetrant mutation. In terms of the male versus female, UBA1 is an X-linked gene, and this functions as a somatic mutation. So an adult patient at some point in life, we don't know when, acquires a UBA1 mutation only in their bone marrow, and it gets reflected into blood. And so females having 2 X alleles are likely protected somewhat, but we have seen cases of monosomy of the X in women presenting with Vexas syndrome. And we're starting to just now find euploid females with 2 X chromosomes who have what looks like Vexas syndrome. But I think is really under-recognized to date in female populations. And in our original cohorts, of our first 25 patients we described, we had no females. And it's taken getting to, over a few hundred patients to start to see female patients with Vexas.
If I may come back to pathophysiology. So you already alluded to it. Vexas is caused by somatic mutations in UBA1, which is involved in ubiquitination. Now, I guess that many clinicians like me do not really remember ubiquitination from medical school. So why is UBA1 important, and why induce mutations in UBA1, hematological and rheumatological changes?
So when we first started talking about this disease, I, just like you, had no idea what I was doing with ubiquination. But there was a scientist named Akeem Warner at the NIH who studies ubiquination. And so he quickly got involved in this project and helped teach a neophyte like myself the basics of ubiquination. Ubiquination is a fundamentally important process for cellular homeostasis. And it does many different things. It affects cell signaling, it affects protein localization, and perhaps the thing that it's most widely known for is you can tag misfolded proteins for degradation by the proteasome system. So a healthy cell needs an intact ubiquitination system. And if you look at the steps of ubiquination, there's three primary steps. There's three classes of enzymes: E1 enzymes, which initiates all cellular ubiquination, E2, and E3. And when you look at E3, there are over 600 E3 enzymes. And a number of genetic diseases, including some autoinflammatory syndromes, have been discovered due to genetic perturbations in the E3 enzymes. It's actually why when we were first looking at the genetic database, David Beck was really interested in the ubiquitin system because he thought we would discover diseases in this space. And we were looking around in a lot of those E3 enzymes for novel diseases. If you backtrack at the E2, there's about 40 of these enzymes, so less specificity. And then you go to E1, the master switch, of which there's two enzymes, UBA1 and UBA6, and UBA1 does about 99% of the work. So we're finding a genetic mutation in the first step of cellular ubiquitination, the master switch of all ubiquitination, and it's why we think this is a somatic mutation. If this were a germline mutation, it would be incompatible with life.
And how comes, if it's such a central process to so many biological processes, that particularly hematological and autoinflammatory symptoms are caused, and why particularly specific sites such as the cartilage of ear and nose?
I wish I knew. That's what we've been thinking a lot about. You know, there's a number of diseases that have been discovered with defects in ubiquitination proteasome system that produce vasculitic and inflammatory phenotypes. Why cartilage involvement, why vessels in this disease, why skin, I don't know. I can tell you there's a fundamental paradox of the disease that we're really trying to understand, which is that this is a toxic mutation. The cells do not like to have this mutation, and it's occurring in stem cells in bone marrow. And so when we biopsy a patient and sort cells and figure out which cells have this UBA1 mutation and which don't, if you look at stem cells in patients with Vexas, there's a high burden. Many of these stem cells have this mutation and have clonally expanded. And then when you chase that through lymphoid lineages, the early lymphoid progenitor cells have the mutation at a very high burden, but when you get to mature T cells and B cells, there's no mutation. So in circulation in blood in these patients, if you look at their T cells, their B cells, they don't have the UBA1 mutation. It's likely negatively selected at the level of the marrow. You know, a B cell that has to deal with immunoglobulin production can't tolerate defects in ubiquitination. But when you look on the myeloid side of things, it gets really interesting because common myeloid progenitors, high burden of this mutation. And then when you get to circulating myeloid cells, so monocytes and neutrophils in these patients, almost all of these cells have this mutation. And what we don't understand, and what is the fundamental paradox of the disease at a cellular level, is why does a toxic mutation expand so, completely through these myeloid lineages? They're not only tolerant of the mutation, but they're expanding at the expense of normal myeloid cells. I think if we understand that, we probably will have better inroads in how to treat the disease.
So another very difficult question, I guess, but how comes that the mutations all affect a single codon? So a codon number 41, you told us it's a hotspot. To my best understanding, and I'm far outside of genetics, but these mutations should actually occur randomly across a given gene. So how comes that this codon 41 is so important?
Yeah, it's a great question. It turns out that UBA1 gene encodes two protein isoforms. There's a long isoform, which is translated at codon 1, a methionine at codon 1, and that isoform goes to the nucleus. And then there is a shorter cytoplasmic isoform of UBA1, and translation of that isoform starts at codon 41, which is exactly where 95% of patients with Vexas have missense mutations. And what we showed in the original report with the Vexas syndrome is that when you mutate this translational start site at codon 41, then you skip forward and translate at the next available methionine, which is codon 67. So you make a shorter version of the cytoplasmic isoform that's catalytically impaired. So you lose cytoplasmic ubiquitylation. Turns out the story is not that simple. And we just put out a paper this week in Blood about looking more deeply at codon 41. And what we're learning is that there is some residual translation of the short isoform that starts at codon 41. We call this one UBA1B. So even with Vexas mutations and they skip forward and they make this catalytically impaired isoform, there is still some production of the native isoform, cytoplasmic isoform, and the degree to which the cell produces that actually relates to the severity of the disease. And the take home from that paper is that patients with Vexas will have missense mutations at codon 41. It'll turn that methionine into one of 3 different amino acids. Patients that have the valine mutation are most likely having the most severe disease, most autoinflammatory looking disease, most vasculitic disease, and they die earlier, with no patient in our cohort surviving longer than 12 years after symptom onset. And at the translational level, the valine variants are the ones that translate the least amount of that UBA1B, the cytoplasmic isoform. So going back to the original case we heard about, if I had to bet, I would say that patient has a 3' mutation in UBA1.
But there are also mutations at position 42 and 40 and 43, but they are not of importance because they would not have this effect upon protein expression, and therefore they are not of clinical concern, actually. That's why these mutations at 41 are of central importance. Did I get it right?
They're the canonical defining mutations of Vexas, but there are some mutations that we're discovering outside of codon 41 that are actually causal for Vexas syndrome, including one described originally in the UK at codon 56, and a couple of them at a intronic splice site just upstream of codon 41. And I'm sure we're going to find more. We just reported actually a patient that has a myositis-like phenotype with Vexas who has 2 novel UBA1 mutations. So I think, we'll continue to expand our understanding of genetics of the disease, but by far and away, the classic Vexas patient has a missense mutation at codon 41.
So my last question before switching the mic to Helen. Again, most of our colleagues who follow Marcus at home are nephrologists. So would you give us a brief explanation again on the major differences between autoinflammation and autoimmunity?
Sure. I think these differences are slightly overstated myself, because I think this all exists on a spectrum. And I will give you an example. So autoinflammation is generally thought to be a myeloid-driven disease, originally described in periodic fever syndromes, where you have mutations in the inflammasome that are constitutively activating myeloid cells and producing a phenotype that looks often like very specific symptoms: fevers, serositis, all the symptoms that we associate with things like familial Mediterranean fever and NOMID and these pediatric onset diseases. In contrast, autoimmunity is often thought to be, the hallmarks of that is involvement of the adaptive rather than the innate immune system, production of autoantibodies, T cell clonality, and we start to then divide diseases into being autoimmune versus autoinflammatory. And in reality, most of the diseases we see as rheumatologists are so complex that there's elements of both. Lupus, Behçet's, most vasculitis, I think kind of, it may skew one way or another, but it's a bit of an artificial distinction in my mind. And when you look at Vexas syndrome, the A in Vexas is autoinflammatory. And it's a classic autoinflammatory disease. It's a myeloid restricted mutation, but that doesn't mean that the adaptive system isn't playing a role in this disease. And you actually, when we do flow cytometry, there's activation of T and B cells in this disease in almost every patient, and adaptive cytokines are elevated, often because these myeloid cells are dying and there's cell non-autonomous secondary effects on the adaptive immune system. So when we treat patients with Vexas syndrome, we often target the myeloid population, but if you give them therapies directed at T cells, they actually have some benefit as well. Nothing's ever as clean as it seems, but these terms I think are helpful as concepts and as teaching principles.
Thank you. So moving on from that, I would say in the adults I see with clear-cut monogenetic autoinflammatory disease, they've had an average of 5 diagnoses before we see them make the right diagnosis, and they're just wrong. They do have a monogenetic disease. In Vexas, the patients clearly have had a lot of alternative diagnoses before the diagnosis of Vexas is made. Sweet syndrome, relapsing polychondritis, polyarthritis nodosa, giant cell arthritis. Do you think that they really do fit into what are clinical diagnoses of complex diseases? Or is this actually something different that is genuinely Vexas associated? So is this an overlap of syndromes with a predisposing factor, or is this a single disease spectrum presenting across a number of different phenotypes?
Yeah, that to me, that's the thing I find most interesting. And that's the thing that I somewhat obsessively think about. Everybody in rheumatology and in medicine in general wants to move towards precision medicine. We want molecular diagnoses, and we want genetic diagnoses if possible. And there will always, in my mind, exist a natural tension between a molecular-driven diagnosis and a clinical one. And I believe it's a complex relationship that should be respected. Does your patient that you presented at the outset have relapsing polychondritis? Yes, they do. That's their clinical diagnosis. It's not an inaccurate one. Their genetic diagnosis is Vexas syndrome. And what we need to figure out is, does the clinical diagnosis matter, or can we just go straight purely to the genetic one? And what we're starting to realize is that, yeah, the clinical diagnosis has prognostic information even within the same genetic syndrome. And it's that interplay that's really important. We are going to struggle with this tension onward and onward as we get better at understanding the biology of our diseases. And I think it's a healthy tension, and it's really interesting and fascinating. But from the perspective of the patients, I think it's really complicated, and we need to be very sensitive to this. In the early days of Vexas syndrome, we would go to a patient with polyarthritis nodosa as their clinical diagnosis and say, you know what, you don't really have true polyarthritis nodosa. You have this genetic diagnosis of Vexas syndrome. We know what's causing your condition, and hopefully this will help us figure out one day how to cure it. Isn't that wonderful? And they would say, what? I identified with this clinical diagnosis. Some of our relapsing polychondritis patients are part of a RP community, and they got support from that community. And they said, I've gotten used to having this rare disease, and I've gotten through it with this community of patients that have this rare disease. And now you're taking that away from me and telling me I have an even more one-of-a-kind rare disease that no one even knows about. So I think we just need to be sensitive to those tensions because they operate on so many different levels. That's a long answer, but
no, I completely agree. Do you think the time is coming when genetics is going to come into the diagnoses of these acquired syndromes, and as part of the diagnostic criteria, you're actually going to be asked, particularly given your work on relapsing polychondritis, to have excluded somatic mosaicism before making a diagnosis?
I hope so. I mean, we talk about in rheumatology, there's diagnostic criteria and diagnosis versus classification criteria. And almost everything that we do in rheumatology is classification based. And even the major rheumatology societies, American College of Rheumatology and EULAR, they do not endorse diagnostic criteria because it's very difficult to create a set of rules that will have perfect sensitivity and specificity, which is what you need for diagnostic criteria. You got to pick every patient up, and you can't have false positives. So we hedge by saying, well, let's just go for classification criteria. We're only trying to define the classic version of a disease so we can have homogeneous research populations for studies. And we don't have to pick up every patient. Not every patient diagnosed with lupus has to fulfill the lupus classification criteria. But as we get genetic diagnoses, we actually may start to be able to create diagnostic criteria that work. And to me, that's incredibly exciting. This is going to creep into the clinic, but it's a ways away. At the NIH, many patients that come through with many different conditions get whole exome sequencing, get genetic testing, reflexively. And this shows the power of that, because this disease was discovered. We recognized this disease clinically about 10 years ago, and it's been described in case reports and case series forever. Vexas is out in the literature forever, just wasn't known as Vexas. But we didn't define it until we actually had next-gen sequencing data available on all comers and were able to look in a clinically agnostic way. David Beck analyzed that data, never looking at the charts. He never was trying to find a clustering of symptoms in stereotypically similar patients or clustering in a family. He was just purely looking at genetic databases. And that's incredibly exciting. And we're such at the very rudimentary, crude beginnings of this process. But I think, there will be a room clinic of the future where you'll get your genetic panel, just like you get. Maybe we will stop doing the C-reactive protein and actually, sequence data on all of our patients.
So crystal ball gazing, a little bit like hyper IgG4 syndrome. Now, Vexas, what do you think for the future? Where's the next disparate group of diseases that are going to get it united with a single acquired genetic diagnosis? Vexas?
I would love to see sarcoidosis disrupted personally, but what I'd love to see is Vexas is a somatic mutation that is happening in adult onset diseases, and many rheumatologic diseases start in adulthood. And it makes no sense to study giant cell arteritis and do germline genetics, trying to find a disease that starts when you're 83 years of age. Yes, it's important. GWAS studies are important, and they will identify susceptibility factors, but those risk factors are going to have very small effect. But a disease like giant cell arteritis, an acquired mutation, a somatic mutation causing that kind of disease, it makes so much sense in a disease that's not passed along very strongly from one family member to the next and one that starts late in life. So I really am excited to think about the role of somatic mutations in rheumatology in general. And we're really at the beginning stages of that, looking for somatic mutations in blood, but also looking for it in tissue. And there's some incredibly exciting work on the emergence of somatic mutations as a causal driving factor in a number of rheumatologic diseases, Erdheim-Chester disease, Sjogren's syndrome, cryoglobulin vasculitis, somatic mutations in B cells producing, pathogenic rheumatoid factor. There's examples of periodic fever syndromes. This list is going to continue to expand and expand. And I think that in my mind, there's going to be so much genetic discovery in adult populations through that paradigm. And as a plug, the American College of Rheumatology, and prior to their annual 2022 convergence meeting, the day before, is having a clinical and basic research symposium day on the role of somatic mutations in rheumatologic diseases. And we've invited a lot of outside speakers from different disciplines that I'm chairing that conference along with Jill Norris. So, I'm really excited at what's going to come from that, because this has the potential to give us what we want, which is cause and cure.
So moving on for that, the association between inflammation and autoinflammation and myelodysplasia is a really hot topic and really interesting. Do you think the bone marrow is uniquely susceptible, or is it actually just uniquely targetable and accessible to us? And if we could look in the lungs and the gut, which are both rapidly turned over systems, are we just missing that because it's so difficult to study?
The latter, yes. We are polyclonal individuals. We are mutating all the time in every tissue bed, and on that background, disease is developing for sure. What is interesting to me about the bone marrow, if you're going to prognosticate, is that there are examples of somatic mutations in stem cells in bone marrow that become lineage restricted to myeloid populations. That's Vexas syndrome, that's Erdheim-Chester. But then there's also somatic mutations in bone marrow that become lineage restricted to lymphocytic populations. Felty syndrome with STAT3 mutations in CD8 T cells is an example of this. It's easier to find those somatic mutations in myeloid populations because they're so abundant in peripheral blood. Much harder to find those smaller clones in lymphocytic populations. But if we go by the autoimmune, autoinflammatory paradigm, it's quite possible that somatic mutations restricted to lymphocytes produce autoimmune diseases, and restricted to myeloid populations produce autoinflammatory diseases. And I think we're going to see more and more examples of that paradigm in bone marrow and in peripheral blood.
So before Andreas and Helen discuss treatment and prognosis, one single question on diagnosis. You have published a diagnostic algorithm based on macroscopic anemia and thrombocytopenia in a paper, I think 1 year ago. Is this algorithm ready for clinical use for us in clinical practice?
So this is an algorithm that Dr. Ferrada and another fellow at the NIAMS program, Iming Luo, helped develop in our cohort of relapsing polychondritis patients. So going back to the original case, this was a male patient with ear chondritis. And you told us at some points that the hemoglobin was low. I don't know what their MCV was, but I would bet that it's probably greater than 100 and that this patient would likely have Vexas syndrome. We put this algorithm out there just as a simplistic way to say, this is a disease that's really easy to spot if you know what you're looking for. And to me, the critical laboratory value is the mean corpuscular volume, the MCV. And we ignore it in rheumatology. And we think that it's due to alcohol use, or we think that it's due to methotrexate, nasothioprin. But if you have a patient who has, treatment refractory inflammation or bad inflammation in skin, cartilage, or lungs, and their MCV is greater than 100, that's a patient, that's a no-brainer. That's a patient that should get screened for Vexas.
Good. So moving on to treatment. So a lot of different treatment forms have been used, but first off, and a bit related to what you just said, what are your parameters actually to measure a treatment response? Is it CRP, ESR, or is it MCV, for instance?
I was listening to Pierre Sugebert from France talk about this, and he outlined it in a really nice way. Like, what are the goals of therapy for Vexas syndrome? And I think there's a couple things to think about. One goal of therapy is to control the inflammatory symptoms. And that's, as rheumatologists, that's what we spend a lot of our time trying to do. But another goal of therapy would be to eradicate the clone. This is driven by a clonal mutation in blood. Can we eliminate that clonal population? And then the third goal of therapy for Vexas is to prevent disease-associated complications. The thromboembolic signal that happens quite frequently. Because the mutation is toxic to lymphocytes, they're very lymphopenic and the patients are susceptible to different opportunistic infections. So I think in that general paradigm, that's how we're thinking about treatment for the disease. I also would like to make the point that for most rheumatologic diseases, we think about them as these relapsing, remitting chronic diseases, and we're trying to find that correct therapy that puts a person into durable and stable remission. But this is a different disease. This is a different animal entirely because this is a progressive disease. This is basically like the cancer paradigm. This is a disease that steadily gets worse over time. And I think we have to be mindful of that as we think about treatment, because in my opinion, the effectiveness of a particular medication is just as dependent on the choice of the medication, but also as to the timing of when it gets initiated. I think the disease will be easier to treat early in the disease course and much more difficult late in the disease course. And it's our job now to identify patients earlier. And what I don't know is if we identify them earlier and institute therapy, is that going to affect the natural history of the disease, which currently is not very good. The median survival in our cohort is about 10 years. Over 25% of our patients have died. It's been really horrible caring for patients with Vexas syndrome and seeing so many of them die from so many different ways. And so we are so excited that when we put the first paper out, that there was international interest and that everybody, it seems like around the world, is working on this disease and thinking about this disease and trying to come up with treatments. And we that's our number one priority, is to try to find more effective treatments, because the mortality rate of the disease is very high.
So coming back to that, and you of course alluded to that already. So there have been a lot of case reports, case series, and of course a lot of different treatment strategies, including tocilizumab, but abatacept. You have put out a paper with a JAK inhibitor. So if you don't have any financial constraints, what would be your first line treatment for Vexas in a standard patient, let's say?
Yeah, I mean, the only thing we know, I will say confidently, the only thing we know that is effective consistently are glucocorticoids. And it's unfortunate because patients have progressive escalating daily glucocorticoid requirements, and the complications from glucocorticoids are quite high. Short of that, I am not convinced that any steroid-sparing therapy is particularly effective. There are some that we think have a little bit more of an efficacy signal than others, but most of them, if they're effective, it's transient, and the patients tend to progress through it. I am definitely excited by the prospect of allogeneic stem cell transplantation as a curative therapy for the disease. And there's definitely a number of patients in our cohort as well who we think have been cured from Vexas by stem cell transplant. The problem is these are an elderly population with comorbidities, so selection of appropriate candidates and the challenges of doing transplant in general make that a procedure that we don't entertain lightly, and we really have to learn more about selection of appropriate candidates. But in my mind, thinking about strategies that are going to eradicate the clone rather than temporize inflammation is what ultimately is going to be successful in this disease. And, we know the pathway. Now we got to learn how do we target how do we exploit our knowledge of this pathway to target and eradicate these clones.
You've already taken away now one of the future questions, actually, about stem cell transplantation. But what about CAR T cells or combined CAR D, CAR B cells? Do you think this might be effective?
I think gene editing therapies may be the way to go with this disease. In my mind, it's a lot like sickle cell, where you have a single amino acid substitution, and sickle cell patients are now being cured by gene editing approaches. And what we don't understand is with sickle cell, you don't have to completely correct the entire marrow. You get most of it and you're good. I don't know about Vexas. And we don't understand, when did this mutation first occur in marrow and how rapidly does it expand? And to what degree can we control it and prevent and ameliorate symptoms? And I think we need animal models, which have been a bit challenging to establish, to start to understand that. And then once we know those fundamental questions, then I think we can be a little bit better informed about trying to develop customized therapies. But to me, it's a disease in theory that could be perfect for gene editing approaches.
You already mentioned the high frequency of thromboembolic events with around 35% roughly. So which patient population are you actually considering eligible for prophylactic prophylaxis, and for how long are you giving that?
We don't know this yet. We've had a lot of discussions about this. There's a hematology and cardiology group at the NIH who are studying thromboinflammation, who've been studying this disease. And we have these discussions. Do we give them prophylactic therapy? And there's really no clear consensus yet. We don't have enough data to guide us one way or another, because the problem with anticoagulation in these patients is that they also have inherent cytopenias and they're thrombocytopenic, and so bleed risks are there. I don't have a good answer for you, but it's an area that needs to be defined.
Thank you. So, as you've already said, the prognosis is pretty poor, and the French excellent French Vexas registry has also strongly supported that. They've published a number of factors that are associated with an increased hazard ratio of dying. Do you use them in counselling your patients about their survival? Do you think that they're actually just marking patients along the disease progression rather than being independent predictors?
Well, so they've looked at a few things, and in our recent blood paper, we have a few prognostic factors. I think that I do think genotype matters. I think that the valine patients do worse. In the French study, they show that the leucine patients do better. And that's true for us too, but their follow-up was about 5 years. And in the first 5 years, the leucines do appear to do better, but then after that, they start to do worse. So over a longer period of time, we think the more durable signal is that the valine mutations do worse. And those are the ones that we think should be potentially considered for curative therapies like transplantation earlier. To me, the biggest prognostic factor ultimately is often what's happening in the marrow. And as they start to become transfusion dependent, that's a time varying risk factor. That's a bad sign. So if a patient starts to rely in what tends to happen hematologically in the disease is they have a macrocytosis first, then they develop a macrocytic anemia. Then over time, they start to develop thrombocytopenia. And at some point, they start to require red blood cell transfusions. And then as it goes on, they start to require platelet transfusions. And when you're in those periods of time, I think that's when there's really bad prognosis. We have a research protocol at the NIH where we're doing stem cell transplantation in Vexas under a research protocol. So we hope to learn more about how to better predict this and prognosticate for this, but it's so early. And like I said earlier, if we initiate therapy, or if we pick these patients up earlier and treat them earlier, can we alter the natural history? The prognostic factors that we are identifying retrospectively, are those going to be the ones that hold up as we prospectively manage this disease? That's what we need to learn.
Do you think there's going to be a functional readout for that? I mean, it's tempting to look at interferon scores in these patients, but do you think we'll get better functional readouts early in line with what you're getting from looking at the actual specific amino acid substitutions?
I don't know, because when you look at various inflammatory pathways in this disease, they're all activated. It's a hyper-inflammatory disease. And so people will approach us and say, I'm really interested in CGAS and STING and pathway and interferon, and we think it's turned on in Vexas. And our answer is, yeah, it likely is. But so is the inflammasome, and so is a number of different cytokines. I think that's the problem with the disease is you can pick any of your favorite inflammatory biomarker and it's elevated in this disease, unfortunately. So I don't know what the appropriate functional readout would look like. And for us right now, we're following genotype and we're following, progressive cytopenia as the biggest prognostic factors.
And finally, stopping with a renal question, the French have recently had a case report of a patient who presented with Vexas and interstitial nephritis requiring dialysis. And we've had a patient also who had a couple of episodes of dialysis-dependent renal failure with interstitial nephritis, both of whom responded to high-dose corticosteroids. Is this a picture you've seen?
No, not really. We haven't seen much in the way of kidney involvement. I thought there would be secondary amyloidosis and all sorts of things happening, but it hasn't come across our radar. I know of one case of ANCA-associated vasculitis that had posse-immune GN with Vexas, which was very odd. But for us, the kidney has been relatively spared in this disease. I'm sure that will not hold up over time because it's a condition that's affected almost every organ system, but it's not a predominant feature of the disease.
So finally, my final freebie question. We've had quite a sad time with COVID in our Vexas cohort, unlike our Schnitzler's cohort. Possibly, I thought, because of the steroids. Again, has that been your experience?
Yes, we unfortunately have had a number of patients with Vexas syndrome die from COVID. I think it's one of the worst diseases to get COVID with because you're an elderly male patient, which are bad prognostic factors for COVID. You have lung involvement with the Vexas, and you have a clotting disease. So we've been really careful in trying to instruct our patients to, minimize exposures. The vaccine responsiveness in the cohort isn't great. It's been tricky. For that reason, we travel a lot of the patients to the NIH for research studies here, and we've been really reticent to do that while the pandemic has been ongoing.
Thank you.
So thanks so much. You answered all our questions. That was really brilliant. Hopefully this will stop germ ignorance on Vexas, and I'm sure that when we see our first patient, we will be aware of Vexas, and this may definitely help our patients. So thanks a lot for doing all this work. Thanks a lot for sharing the last hour with us. So it was brilliant. Hopefully we will meet one day again with the next story on this. Thank you.
Thank you.